Pediatric urology is actually a really tricky subject. It's also fairly low yield in the way of the step exams on the shelf because it's so hyper-specialized. What I want to do in this video is use it as an opportunity to explore the anatomy of the genitourinary system, consider hematuria, come up with the differential for what might cause problems with the kidney, and then go through some of the diagnostic tests and how you use them in kids, because it's very different than in adults. On the back half of the lecture, we'll close with a couple of diseases you have to know, especially if you're going to go for a 250 or higher. Start off with the genitourinary system. You've got a kidney on one side and a kidney on the other. The renal pelvis gives rise to the ureters. Ureters come, connect with the bladder. Bladder stores urine and sends it out through the urethra. So we can break the genitourinary system down by location of problem. We'll start with that. At the level of the urethra, you can have posterior urethral valves, hypospadias and epispadias. A little higher up, you come to the bladder. At the level of the bladder, you're going to have issues with hematuria. But hematuria is going to be, at the level of the bladder, non-glomerular. We'll talk a little bit more about what that means. And the bladder is merely a surrogate for any problem along the genitourinary system. And you'll notice that the adult diseases we talk about in the urology lectures are very similar to the bladder stuff here, so we're really not going to spend that much time on the bladder. At the level of the ureters, you can have three major problems. Uretero-pelvic junction obstruction, and its cousin, uretero-vesicular junction obstruction. That is, it just depends where you are in the connection. Ectopic ureter, formerly called low implantation of the ureter, and vesiculo-ureter reflux. Now, the good thing is, if you understand the Latin, understanding what's going on is not that hard, but let's build the differential first, and then we'll bring it back around to the individual diseases. And lastly, at the level of the kidney, this is where you're going to have malignancy. In a kid, it's going to be things like Wilms tumors rather than renal cell carcinoma, and you're going to have the other form of hematuria, that is the glomerular causes. All right, so now that we have sort of this framework for approaching the genitourinary system, let's talk about hematuria and the tests we're going to use in kids. First, when you hear the word hematuria, you have to have a couple of things in mind. And the first thing is to consider, is it micro or macro? And you're going to use the urinalysis for this. And actually, you can just look at it. Because if you can't tell there's blood in it, and it just happens to be a couple red blood cells on the urinalysis, that's microscopic hematuria. And generally, that is going to be self-limiting. It is definitely true in adults. It is usually true in kids. And the only real exception you have at this level is if they had blunt trauma, then you might want to do the CT scan. Otherwise, you can watch and wait. Don't ignore it, because if the microscopic hematuria doesn't go away, there usually isn't a really good reason for a kid to have persistent microscopic hematuria except for a congenital defect. But at first glance, microscopic hematuria in a kid, much like an adult, no need to push hard. On the other hand, if there's frank hematuria, that is macro, then you need more investigation. And you're going to look at the urine micro to help you. Because what you're going to find is one of three things. If you have dysmorphic cells, that is red blood cells that have been squeezed through a net or a mesh, or red blood cell casts, you're looking at glomerular disease. Dysmorphic red blood cells and red blood cell casts are indicative of glomerular disease. And in this case, you're generally going to make the diagnosis with your urinalysis, and if you really need it, a kidney biopsy. This is where you're getting into the nephritic syndromes, the glomerulonephritis that you learned about in step 1. Don't go back there, just know that that's where you end up. If on the other side of this, you have normal red blood cells and no casts, then you've got non-glomerular causes. And non-glomerular causes is the surrogate bladder here we're talking about. That's going to be the kidney stones, the malignancies, the stuff in the lumen, anywhere from the kidney to the urethra, including trauma, stones, cancer. The non-glomerular causes are going to be investigated first with an ultrasound, and as you'll find, the ultrasound is usually the place to start in kids because there's no radiation burden and it's non-invasive. Then you'll need to decide between a cystoscopy, and a cystoscopy is simply a camera, a colonoscopy of the bladder, which can lead to a ureteroscopy, versus systemic imaging like a CT or MRI. And it's going to be dependent on your pretest probability. Is this an intraluminal lesion, or is this something sitting on the kidney pole? You won't have to make that distinction, just recognize that there's a couple of things we can do. Right, so there's a couple of things we can do. So let's talk about those diagnostic tests. The first of which is the ultrasound. You also have a voiding cystourethrogram, a CT scan, a camera, cystoscopy, and an intravenous pyelogram. I'm going to tell you right now, the intravenous pyelogram is effectively never the right answer. You might as well just do the CT scan, because what you're doing is giving intravenous contrast and taking x-rays. It's the same thing as a CT scan with IV contrast. Yes, the CT scan does provide extra radiation burden, but if you're at that point, it's probably worth it. The ultrasound is usually the first step. What the ultrasound does really well is not show you where the ureters are or where the kidney is. What it shows you is hydro or not. And hydro is usually associated with obstruction. But in the case of kids, it could also be reflux. So wouldn't it be cool if you had a test that could differentiate, if you have hydro, is this from obstruction or is it from reflux? Well, the voiding cystourethrogram is just that. When you put a catheter in and inject dye into the bladder, you remove the catheter and have the kid pee. The bladder should contract and all of the dye should go through the urethra. That's normal. But if it ends up in the ureters for some reason, that's a sign that there's reflux. So the voiding cystourethrogram really is designed to show you reflux or no. It has other utility. It can show diverticula and some weird, very large abnormalities on the bladder. But primarily what it does is that hydro from reflux? Start with ultrasound, then get a voiding cystourethrogram. The CT scan and the cystoscopy, as we talked about just a moment ago, is usually used as the last steps to investigate whether or not the bleeding they have or the lesion they have is in the lumen or on top of the kidney. So the cystoscopy is going to be used for intraluminal lesions. Bladder hematomas, bladder cancers. Generally not going to be the right answer for kids, but the cystoscopy gives you access to the ureters, so you might be able to fix some of the problems we're going to talk about while you're in there with the camera. Sometimes you need full surgery. The CT scan is going to be used in one of two conditions. One is going to be trauma. And for trauma, you're going to use IV contrast. You want to know if anything is leaking. And you can see that on the CT scan through the entire general urinary system. The other time you're going to use the CT scan is if you think there are stones. And stones are going to use non-contrast. The idea being you want to see the radio-opaque stone, and if you've got radio-opaque contrast right up against the stone, you won't see it. So primarily you're going to be using ultrasound and voiding cystourethograms in kids. And every once in a while, as they progress, you're going to end up with CT scan and cystoscopies. You're never going to pick intravenous pyelogram as the right answer. And every once in a while, you'll have the renal biopsy. That's probably going to be the wrong answer as well on your test. Okay, we've got our differential, workup for hematuria, introduction of the tests you might get and when, and then also sort of the breakdown of those tests you might do. Let's now talk about the individual diseases. And let's start off with the bottom and work our way up. So the first thing we want to talk about is the posterior urethral valves. The problem here is that from day one, baby cannot get urine out of the bladder. There is redundant tissue that effectively causes a post-obstructive uropathy. It's very similar to BPH in an old guy. Something blocks the urine from getting out of the bladder. And as the bladder gets bigger, it's only going to go one way, and that's back up the ureters. That's going to lead to hydro. So the patient may already know about this. Right? One of the ways you can assess this is when they have prenatal care, they're going to have oligohydramnios. Oligohydramnios because amniotic fluid is created by baby's urine. Babies can't get the urine out of the bladder, well, there's not going to be any amniotic fluid. And that's probably going to prompt an ultrasound or two, and you might actually see the prenatal diagnosis by seeing hydro on a prenatal ultrasound. Chances are they're not going to be that nice to you. So they're going to give you a patient who doesn't have prenatal care, undocumented immigrant, someone who just arrived from out of the country, and now baby's being born. So if you have posterior urethral valves and you can't get urine out of the bladder, what you're going to present with is no urinary output and a distended bladder. The idea here is that the kidneys are still making the urine. So the urine's going into the bladder, it just has nowhere to go, so the bladder gets big. And you might not even get a clue on lab work because there may be an elevated creatinine, but since mom is clearing the baby's creatinine for it, the creatinine may be normal, even though the urinary output is 0. As you'll find, when it comes to the genital urinary system, the first test is an ultrasound. And the ultrasound is going to show you hydro. And then you're going to get a voiding cystourethrogram to rule out reflux. But just like BPH, you're going to insert a catheter. And when you do, you're going to have massive urinary output. You decompress the bladder, and everything just goes the right way. With that catheter in place, you have relieved the obstruction. But you know you're going to have to get in there and fix the anatomic problem, so surgery is going to be the ultimate answer. The other two diseases, hypo and epispadias, are more cosmetic. Hypo and epispadias. When you remember this, think of an erect penis. What is supposed to happen when you transform a female into a male is you grab the top of the vagina and the bottom, turn them into zippers, and literally just pull out and zip everything up. That is, the labia forms the scrotum, the clitoris expands, and the urethra comes with it. And the idea is that you zip them together so that they fold in the middle, and the urethral opening is in the middle. Well, if one zipper moves too fast or the other one too slow relatively, the urethra is going to end up at a different spot. Think of the erect penis, erect, on top epidorsal. Hypo, bottom, ventral. If it helps you remember it, epispadias will cause the kid to pee in his own face. Now, you're going to notice this. I mean, it's there. And the diagnosis is made clinically. And babies are incontinent of urine anyway, so you actually don't really care for the first couple of years. They're in diapers. But eventually you want to get that cosmetic deformity fixed so that they can actually pee like normal. The thing you have to know for your test, and the thing you have to know for life, is that you never do a circumcision. You need that extra tissue to rebuild the urethra. You're going to need the foreskin to reconstruct the penis to put the urethra where it's supposed to be. These two are not so hard. The bladder we already talked about, hematuria, the same thing with the kidney, glomerular versus non-glomerular. Let's talk about the ureteral problems. The first one we want to talk about is the uretero-pelvic junction obstruction, and its cousin, the uretero-vesicular junction obstruction. This is the kidney. Here is the ureter. At the uretero-pelvic junction, it's the renal pelvis that's obstructed. So you're going to get hydro of the kidney, but the ureter is the same. In uretero-vesicular, you're going to have some obstruction at the level of the bladder, so that you're going to have full hydro of everything. Uretero-pelvic, uretero-vesicular, it tells you where you are in the name. Let's talk about uretero-pelvic junction obstruction. The pathology here is that you have a narrow lumen, but it's not narrowed enough to cause substantial problems, because at normal urinary flows, it works. And the patient is going to be exactly that. They're going to be normal for most of their life at normal urinary flows. But when they have an increased flow, they simulate an obstruction. Now, it's possible that someone challenges their friend to a Gatorade drinking contest and has a high volume diuresis. But generally the way this presents is going to be a teenager. A teenager who's been through life without any difficulty. Then they have their first alcohol binge. Drink a bunch of beer. At the same time, they're taking a large volume, the beer, and they're having large diuresis from the alcohol. That then produces a colicky abdominal pain. That then spontaneously resolves. The idea is, partied, increased urinary flow too fast for the narrowed lumen caused obstructive symptoms. But then once the diuretic load was gone, back to normal flow, kid was doing good again. The diagnosis begins with an ultrasound. And for uretero-pelvic junction obstruction, what you're going to see is hydronephrosis. But you're going to see hydronephrosis without hydroureter. And because whenever you see hydro, you know the next step is to do a voiding cystourethrogram, and you're going to rule out reflux. This is more important for the uretero-vesicular obstruction to make sure this isn't from reflux. And when it's not, you're going to do surgery. And you might stent to keep it open, but generally surgery is going to be the answer. The problem is at the renal pelvis. Now, if you talk about an ectopic ureter, formerly called low implantation, what happens is that you've got one good ureter doing exactly what it's supposed to do. And then you've got one ureter which is doing whatever it wants. So you've got a normal one that goes to the bladder exactly the way you're supposed to. Then you have an abnormal one which goes ectopic, which means it implants anywhere. The way the anatomy works in boys, the ectopic ureter is always going to implant above the external sphincter, which means that it doesn't matter. In boys, completely asymptomatic. But in girls, girls are going to have a normal urinary behavior. Right? The good ureter is filling the bladder gets too big, she feels like she needs to go, and she voids. So there's normal function. And because that other ureter can implant below the external sphincter or even into the vagina, what she's going to have is a constant leak. And she will never have been dry because she has had an anatomic deficiency, a congenital defect, which prevents her from holding her urine. The diagnosis is going to begin with an ultrasound. It's not going to show you any hydro. Avoiding cystourethrogram will rule out reflux. And then you're going to do a radionucleotide scan, something we haven't mentioned before. This is going to assess renal function. And because it's low implanted or it's ectopic, you simply need to pick it up and move it. The idea here is that this is going to present very similarly to a fistula, except she's not going to have any reason to have a fistula. She's going to be 5 years old. So think of ectopic ureter when a girl is having normal bladder function and at the same time has never been dry. Lastly, we're going to talk about vesiculo-ureteral reflux. What's supposed to happen is urine comes down through the ureters, goes into the bladder, valves close, bladder pushes the urine out the urethra. Well, with reflux, for whatever reason, it ends up going back up the ureters, not where it's supposed to go. That's called retrograde flow. The patient is probably going to be diagnosed on a prenatal ultrasound showing hydro. You usually have the answer before you're even born. But again, they're not going to be that nice to you, so they'll give you an immigrant or someone who just moved or someone who doesn't have health care or health insurance, so here's baby. The patient who's not diagnosed prenatally is going to present with recurrent UTIs. And most importantly, pyelo. There's not a good reason for kids to get pyelo. So if someone's presenting with pyelo, they probably have some congenital defect that they need worked out. The diagnosis is going to start with an ultrasound, which will show you hydro. Then you get the voiding cystourethrogram, which will show you positive reflux. Therein lies the diagnosis. To treat it, because as these kids grow, they may actually outgrow the reflux, it is possible to use suppressive antibiotics if it's not that severe and hope they grow out of it. But ultimately, because it's a congenital problem, surgery is going to be the answer. All right, if we go back over this lecture, we talked a little bit about a differential based on anatomy. We talked about hematuria. We talked about the diagnostic tests and how you're normally going to go ultrasound voiding cystourethrogram. Then we ran through the major diseases you've got to know from urology. Posterior urethral valves, no urine on day 1, distended bladder, decompress the bladder. Hyponepispadias, don't circumcise. You're going to need that tissue to rebuild the penis and urethra. For ureteropelvic junction obstruction, look for the hydro in the kidneys, but no hydro in the ureter, and that teenager who has a high volume load and it looks like an obstruction, but only at high flow rates. Ectopic ureter is the girl who has normal function and has a constant leak who's never been dry. Vesiculo-ureteral reflux is going to be the kid who has a prenatal diagnosis or is going to present with recurrent UTIs or pyelonephritis. That is pediatric urology.